Yeah, good evening, ladies and gentlemen. Welcome to this morbidity mortality meeting. We are figuring an interesting case of how one should approach a situation when there is a significant comorbidity, and what are the kind of palliative measures that are available to us, what is its effectivity if surgery cannot be undertaken. At least for the youngsters here, the students, there will be a fair amount of learning about the role of stenting and certain other aspects of conservative treatment of a gastric outflow obstruction from a neoplasm in a patient with serious morbidity. Okay, over to you, Pawan. Please carry on.
Thank you, sir. Sir, am I audible, sir?
Yes, you are. Your slides are seen as well.
Okay, sir. Good evening, everyone. I am Dr. Pawan Kumar, second year DNB resident from Saga Hospitals. Welcome to this month's mortality and morbidity session. A 69 years old gentleman admitted on 4th Jan with complaints of vomiting and bloating sensation since 1 month, with history of undigested food particles, loss of appetite, and weight loss of 10 kg in 3 months. Patient has constipation also, and he was passing stools once in 3 to 4 days. There was no other complaints. He underwent surgery for fracture femur in 2016, and there is no significant family history. On general examination, patient was conscious and well oriented, but he was poorly built and undernourished. There was no pallor, icterus, cyanosis, clubbing, edema, and generalized lymphedema, and his vitals were stable. On systemic examination, CVS and RS were normal. On parabdominal examination, we noticed fullness in the epigastrium with visible gastric peristalsis. Umbilicus was normal and left supraclavicular fossa was free. There was no tenderness, guarding, and rigidity. He underwent upper GI endoscopy on 23rd December, which showed gastric outlet obstruction with proliferative growth and at the pyloric end, beyond which scope could not be passed and suggestive of malignancy. And we took biopsy which showed well differentiated adenocarcinoma. PET CT scan was done on 25th December, which showed irregular circumferential mural growth in antropyloric region of stomach, predominantly in the greater curvature, and there was a significant luminal narrowing and with multiple enlarged metabolic active lymph nodes in perilesional, gastrohepatic, left gastric and periduodenal region, suggestive of metastasis. Blood investigations were normal, except there was a little rise in the TLC. Chest X-ray, 2D echo, and ECG were normal. We planned for exploratory laparotomy and radical.
One sec, Pawan. Indraja, yes. Can you come in and make any comments about the investigations that were done? Is there something that you would have done differently? Just go back, Pawan, in your slides. Go back one more. Yeah. So after examination, Pawan is reporting an OGD. Okay. And I believe that when you report something, the order in which you report is important. So I'm sure they would have done the blood tests first, right, Pawan?
Yes, sir.
So that should have come first. And then you would do an esophagoduodenoscopy. And the very next thing you're showing us is a PET CT.
Yes, sir.
Indraja, your comments.
Over the endoscopy, it has confirmed that it is a malignancy.
Mm-hmm.
So in order to decide about the further treatment and to stage the disease, so we need the further investigations to look for any metastasis to other organs.
Okay.
So whatever it is
the
done,
next step to OGD is, in your view, PET CT. Hari?
Sir, contrast CT abdomen, sir, being accept.
Contrast CT. You don't think ultrasound has any role to play?
Yes, sir. Ultrasound, we have to. Yes, sir.
Yeah. Niranjan, I have a feeling that you would have done the ultrasound. Madilva, what
Sir,
is the?
sir, I will just explain the sequence.
Yeah.
Patient actually had gone to the medical gastro department first with the symptoms.
Mhm.
So they had straight away done OGD
Mhm.
and biopsy,
Right.
and patient came with a diagnosis. If the patient would have come with those symptoms, I would have done an ultrasound first,
Mhm.
and then probably depending on this thing, endoscopy also
All
sequentially.
right. All right.
So since the patient came already with the diagnosis of CA stomach,
Mhm.
and shall I tell the answer or you want to ask them further
No, you can give the answer because the
regarding
voice.
CT and PCT? Yeah,
Mm.
patient had a long duration of symptoms, one thing,
Yeah.
and patient was not looking that good with respect to his build and the nutrition and all that.
Right.
So, and there was monetary issue also. So one more decision for doing straight away PET CT was monetary issue, because in hospital, if you
Mhm.
ask for CT, chest and CT, abdomen and pelvis,
Mhm.
it will cost around 20, 24 like that.
Mhm.
So PET CT, one advantage is probably the metastatic workup will be done in one single investigation, and cost will be much more lesser,
Okay.
because 13.5 we could can get it done. So that was the thought behind getting a PET CT done.
All right. Ravi.
And probably if there was meds, we could have managed him palliatively, because he was not an ideal candidate for surgery, even
Right.
without those morbidities which happened later.
All right. Ravi, what are your views about it?
I think for the benefit of the students, the CA stomach is not one of the definitive indications for PET CT as far as academically oriented approach is concerned. I think the PET CT should usually be reserved for lymphomas, small cell carcinoma of the lung. I think those are the two strongest indications for preoperative PET CT.
Yeah.
Then others, as Niranjan has explained, probably considering other things. But in the examination, if the examiner asks you, would you do PET CT as an investigation? You should say I wouldn't, sir.
Yeah.
But I think you can understand the reasons behind doing it. But I think if you go through an MDT for a PET CT, will not qualify as one of the investigations.
Correct. Ramakrishna?
And current NCCN guidelines, option of CT abdomen, pelvis and CT chest or PET CT is there if you are clinically suspecting metastatic disease.
Yeah. But I would submit, Niranjan, that
Yes,
if
sir.
cost is an issue,
Yeah.
as you have made out, I would be happy with a chest X-ray and an ultrasound before I operate on a CA stomach with gastric outflow obstruction.
Okay.
Yeah. And that is still the standard of practice, I believe. I do not think for every CA stomach you need to get either PET CT or a chest and abdominal CT. That is, Ramakrishna, you have any comments?
Yes, sir. I was about to say what you said just now.
Yeah.
One surprising thing is his hemoglobin. It is maintained at near normal.
Yeah.
It is difficult to explain that. That is one thing.
Yeah.
Investigation wise, we usually in periphery we don't have much facility, so we do CT scan after endoscopy. Endoscopic proven disease. Sometimes with ultrasound also we proceed, and chest X-ray is required.
Yeah. Okay. Any other comment, Srikanth?
Yeah, after endoscopic confirmation, next line will be the ultrasound or CT, depending upon patient's economic conditions or something.
The point I'm making,
and then chest X-ray.
Yeah, the point I'm making is this person has a gastric outflow obstruction.
Yeah.
Okay, and so even for palliation, you can go in for surgery with fewer investigations.
Yes.
Even if this patient had a metastasis in the liver, for example, based only on the ultrasound, you might then say I'll palliate with a stent or whatever. But if you want to, you can even do a gastrectomy, partial gastrectomy, to give it a palliation. It's not a curative gastrectomy, and that is, you're justified in doing that, particularly when the patient's finances do not allow higher investigations. Okay, go on,
The PET CT doesn't give any additional information compared to CT.
Yes, but Niranjan made the valid point that a combination of chest and abdominal CT costs more than a PET CT.
Oh,
Yeah.
why
Go on.
CT chest?
You want to look at metastatic workup, no?
Oh,
I'm submitting that chest X-ray is good enough for me, even
that's
though it's,
enough for me. Yes.
yeah, that is the point of discussion. Yeah.
Hmm.
Go on.
Yes, sir. We planned for exploratory laparotomy, radical distal gastrectomy, gastroduodenostomy, and jejunojejunostomy on 7th Jan. So we admitted the patient for optimization before surgery on 4th Jan. Patient was started on TPN and stomach wash was given. Physician and cardiologist opinion on fitness for surgery was also taken.
Just go back, Pavan.
Yes, sir.
Hari, can you come in? Maybe we should talk to Kavya. Kavya, welcome back. I thought I heard you had gone away. All right.
Good evening, sir.
Good evening. So they have a plan of they started TPN on the 4th, and they were planning to, after optimization, they were planning to operate on the 7th. What is
Yes,
your
sir.
understanding of nutritional optimization?
So in this patient, sir, he's already emaciated.
Yeah.
And orally also is having gastric outlet obstruction and is already vomiting.
Correct.
So we have preferred to optimize him through TPN.
Yeah.
Before surgery itself, so that
Yeah.
even after surgery, if he's on Nilper oral for a few more days,
Yeah.
we can continue to resuscitate.
When do you think this person will be in a positive metabolic state before you can actually operate on him nutritionally? fact-
So TPN at least 5 days before surgery.
That is the point I was looking for. Okay. It is,
Yes.
studies have shown that if you want to put somebody in a positive nitrogen balance,
Okay.
positive metabolic state, the minimum time required is 5 days.
Yes.
So 3 days would not have helped. That is the teaching point for the youngsters here. Okay.
Yeah.
5 days is what you need to give. Okay. Go on.
Yes, sir. However, on 6th Jan at night 9:30, patient had giddiness and become unresponsive with reduced saturation. So he was taken to medical ICU. On examination, patient was gasping with tachypnea and had pulse rate 140 per minute and BP 60/30 and SpO2 around 70 to 80 with low GCS. So patient was intubated and started noradrenaline at a rate of 5 ml per hour. Post intubation, the vitals were BP 60/40 and pulse rate 134 per minute and SpO2 100% on 100% FiO2. As per cardiologist review, ECG and 2D echo was done, which showed anterior wall myocardial infarction with ejection fraction of 45%. And as the patient has sudden unresponsiveness, neurologist opinion was taken and MRI brain was done, which showed small wedge-shaped acute infarct in the right frontal cortex with hyperacute ischemia are seen in the bilateral parietal cortex. Chest X-ray was done, which showed normal.
Just go back.
Condition.
Just go back.
Yes, sir.
Pavan, just
Yes.
go back. Indraja, can you read this chest X-ray for me, please?
Chest X-ray of the AP view, sir.
Is chest X-ray usually AP?
No, sir. Generally, we'll do in PA view because
Okay.
patient is on lying down position, can't stand.
All right.
So that's why they have done the AP view.
Correct. Go on. Yeah. Unfortunately, everything is written on the left, but I want to see if you can read an X-ray properly. Yeah. Okay.
And it is showing the central line, sir. Here.
Okay. Is that the next thing you say after a chest X-ray? We have discussed this before, so I'm just trying to see if you can. You said it's an AP view. What's the next thing you say? What about the rotation? Is the rotation okay? How do you know whether it is straight on or whether it is rotated?
The trachea should be in central line, sir.
Trachea is not necessarily the one. What is even more important than trachea? Trachea can be shifted by something else, right? So you
Yes.
can't say, yeah. So what do you look at to know whether the chest X-ray is rotated or not? Pavan,
Sir, spine, sir.
no? Hari,
Hello, sir.
yeah.
Sir, clavicular distance, sir.
Sternoclavicular joints,
Sternoclavicular
are they
joint.
symmetrical? Okay. Sternoclavicular joints. Spine can be rotated. The patient can have, kyphosis, scoliosis, you name it. So those are all not the thing. The sternoclavicular joints must be symmetrical, which it is in this case. For a portable X-ray, I thought this was an excellent X-ray. Okay, what else? Go on. Indraja.
We have to see the postophrenic angle.
Central line is in place. Is it in the right place?
Yes, sir.
Where do you expect it to be if it's in the right place? Where do you expect the tip? Do you see the tip?
Yes, sir. I'm able to
You can see the tip.
No.
Yeah, it's difficult to see. It seems to be a fair way down the SVC. Okay.
Yes, sir.
Yeah. So it may be in the right place, or it could even be sitting in the right atrium. Okay. All right. Go on.
And we have to look for the postophrenic.
There is an endotracheal tube, right?
Yes, sir.
Okay. So
They
with
are
that,
eating.
what's happening? The patient is on a ventilator, I presume.
Yes, sir. Yes,
Why
sir.
do I say the patient is on a ventilator? One of them obviously is that the patient has an endotracheal tube, but what is the other clear indicator in this X-ray that he's on a ventilator? What is the status of the diaphragms? Is it flatter, or is it as globular or dome shaped as it should be?
It's flatter, sir.
It's flatter, right? That's why I say the patient is on a ventilator. Okay, what else? You can't not say anything. Then you talk about the bony structure. Okay.
Yes, sir.
The spine is straight, ribs look normal.
Yes, sir.
Next, you talk about the lung,
Okay.
upper, mid, and lower zone. Next, costophrenic angle.
Yes, sir.
You understand that all these are important when you're asked to talk about an X-ray.
Okay, sir.
Okay. So it's not just enough that central line is in place, endotracheal tube is in place. Not good enough. Okay.
Okay, sir.
Please remember this.
Yes, sir. Sure.
Okay. Go on, Pavan.
In view of patient conditions, as per the opinion of neurologist, cardiologist, and physician, surgery was deferred for now and was decided to manage the patient non-surgically. Gastroenterologist review was sought for gastrodudenal stenting, and medical oncologist opinion that patient is not fit for chemotherapy presently, and he suggested leucovorin with 5-fluorouracil or liposomal docetaxel based therapy once patient gets stable. Patient was still on ventilator on 7th January. TPN and IV fluids were continued. BP was 120/70 with noradrenaline at a rate of 6 ml per hour. And patient has weakness in the upper limb with power of 3/5 and in the lower limb with power 1 to 2/5 with good urine output. Blood investigation showed elevated TLC and troponin levels. Patient vitals was stable with reduced weakness in the left upper and lower limbs with good urine output, and he was extubated on 8th January, and inotropes were stopped on 9th Jan and shifted to ward on 10th January. The blood investigations of 8th, 9th, and 10th Jan are shown here. Post shifting to ward, TPN was continued.
Just go back, Pavan. Sorry.
Yes, sir.
Now, patient was extubated on the 8th, right?
Yes, sir.
Yeah. Inotropes were taken out. And again, Kavya, would you be doing these things every day? in a patient who I presume by what is reported is improving.
Yes, sir.
Why would you
Patient-
do that?
Because the patient is on ventilator and also he has what do you say?
He came off the ventilator on the 8th, right?
Yes, sir. Still he's on TPN, so electrolytes and all I would like to monitor.
What is this is the point I wanted to come to. What is the recommended guideline for monitoring various parameters for a patient on TPN? What are the parameters that you monitor?
So first glucose and fluid electrolyte balance, sir.
Okay.
Glucose would be 6 hourly and the patient weight and if permissible, and daily complete blood counts, electrolytes and creatinine levels. And also once in 3 days LFTs and the
Yeah, I think LFTs. Okay, and I think you're being very generous. You can do the
weekly.
Sugar. Yeah, sugar has to be done
6
every day.
hourly. Yeah.
Initially 6 hourly on the day you start, and then once you know that the patient is stable, you can do it twice a day. Sugars has to be done every day, maybe even 3 times a day if he's unstable. Electrolytes twice a week and LFTs once a week. Okay, that is the important thing. Okay, go on. Go on, Pan.
Yes, sir. TPN was continued post shifting toward, and patient vitals were stable, and enteral stenting was planned for 13th June. Cardiologist and neurologist.
Just wait for some time. Comments from the seniors, please. Ravi?
So far, I think it's okay. I think
everything is covered. Yeah. Niranjan, you want to make any comments?
Sir, sorry, I had a call. I missed the question.
No problem. Any comments until this point, but it's okay. Nothing very serious. Yeah. Ramkrishna, you want to make any comments?
Nothing, sir.
Yeah. Okay.
Because of patient's condition, the surgery is cancelled. Correct. And I think it is justified.
Yeah. Shrikant, anything?
No, sir. Thorough.
All right. Go on.
Cardiologist and neurologist opinion was taken for stenting. With high risk, patient underwent gastroscopy and enteral gastroduodenal self-expanding metallic stenting on 13th June. The report is shown here, and this is the metallic stent placed at the narrowing site. After stenting on day 1, patient was given clear liquids, and he had one episode of non-bilious vomiting. On day 2, patient started on clear liquids, and he had 2 to 3 episodes of non-bilious vomiting. So, in view of multiple episodes of vomiting, it is decided to do oral gastrography study, which showed stent was in situ and dye going beyond the duodenum freely. In view of hyperkalemia, potassium binding and supporting medications were given. On day 3, post-stenting, that is June 16th, potassium levels were normal, hence K-bind was stopped. On 17th June, patient tolerating liquid diet with no vomiting, and medical oncologist advised palliative chemotherapy with liposomal docetaxel with 25% dose reduction in OPD basis. On 18th June, patient tolerated soft diet with no vomitings, and hence patient was discharged on 19th January.
Okay, just go back one slide.
Yes, sir.
Why do you think the patient was vomiting even though he had no outflow obstruction? Indraja.
After placing the stent, he had vomiting, sir.
Yeah.
Maybe there is a chance of stent migration also.
No, the stent, they proved subsequently that the stent was normal. So why do you think he was vomiting?
because of the in gastroparesis also. So because he's starving all these days.
Not starvation, neoplasm itself
Yes. Okay.
can affect the motility of the stomach.
Okay.
Okay, many times it's known. Earlier, they used to do what's called a divine exclusion, or even now, sometimes people do a gastrojejunostomy for outflow obstruction. Okay, if they have no access to a stent.
Yes.
But you find that even though the anastomosis itself is patent, they hardly ever drain well, because there is a element of gastroparesis when there is a neoplasm of the stomach. Electrolyte disturbances can also do that. So that could also be a reason why the patient is vomiting, even though I must say hypokalemia is lot more common than hyperkalemia in terms of giving vomiting.
Yes.
Okay, but I think gastroparesis is an issue. So it will eventually settle down. And that's what happened in this case. Okay. Incidentally, you mentioned about stent migration. In this process, what are the, I know that Pawan is going to show something about it, but what are the complications of the stent? Difficulties and complications of the stent?
Perforation, sir.
Yes,
Perforation
good.
And stent
Why
migration.
does perforation occur?
It may be that iatrogenic perforation or
It is always iatrogenic when you're putting a stent and it perforates. But why does it happen? What is the mechanism of perforation? In other words, I'm asking you, do you know the steps of putting a stent in, which I think at least the basics you must know? Hari, can you come in and enlighten us?
Sir, encephalation.
Sorry?
so.
Can you hear me, sir?
No, I can hear you. Go on.
Yes, sir. Sir, insufflation, like air while putting.
Insufflation doesn't cause perforation.
Like distension.
No, that doesn't cause perforation. Yeah.
Or else, sir, weakened portion, sir, like when you put expand the stone.
Tumors can be soft. If there's a Skirrus reaction, which is fibrosis, it will be firm. It won't split. Otherwise, when you put a stent through, it can actually split the tumor. Or if your guide wire, which you would have put before putting the stent in, if that perforates or if it gets misplaced, you may have a perforation. Third, many times they need a bit of prior dilatation before they can put the SEMS in. When it is so tight, if you cannot put it across the stricture, the malignant stricture, you have to dilate that before you do the actual stenting, which expands slowly afterwards. In that process of dilatation can cause perforation. These are the reasons they can perforate. So Indraja, coming back to you, you mentioned about stent perforation and stent migration. What are the other complications?
There may be like aspiration, sir.
Aspiration because of a stent? Not really. Definitely not gastroduodenal. You might think about it with an esophageal stent.
It may block, sir.
Yes, it may block. Yes. And it may bleed.
Yes.
With all the expansion and all that, the tumor may bleed. So these are the common complications of a stent. Go on, Pawan.
Yes. Upper GI stents are used to maintain bowel.
One small question before this. Instead of any role for PEG in this case?
Yeah, I should have said, yeah. Any role for PEG? Go on, students, answer. Any role for PEG? There is a gastric outflow obstruction. What will you do with a PEG?
Sir, PEG we can't because it is the distal gastric, sir. So we can do with either stenting or gastrojejunostomy. I mean, generally, yes.
Yeah, agreed. Go on.
Upper GI stents.
Voice is breaking.
Used
Pawan.
to maintain bowel luminal patency to increase nutritional intake. So now, sir.
Yeah, better now. Go on.
Better.
Yes, sir. Upper GI stents are used to maintain bowel luminal patency to increase nutritional intake. These are mainly developed to reduce malignant obstructions caused by
Again, we're losing your
cancer,
audio.
gastric cancer, periampullary cancer, and other malignancies that directly invade the upper GI tract. And The disadvantages like recurrent obstruction and stent related complications. Recently, several types of flexible and self-expandable upper GI stents were developed, like self-expanding metallic stents and self-expanding expandable plastic stents. Metal stents are made up of stainless steel and alloys and have higher degree of flexibility and are capable to generating high radial forces to maintain stent patency and position. These are the indications, advantages and disadvantages of various types of stents as shown here. When there is a gastroduodenal obstruction, to avoid obstructing biliary drainage, uncovered SEMs are used. This has low risk of migration and high risk of tumor ingrowth. When there is a high risk of migration in patients who is not suitable for fully covered SEMs, then partially covered SEMs are used. It has intermediate risk of migration and tumor ingrowth and is difficult to remove. In case of high risk of tumor ingrowth and in benign strictures, as a temporary measure, fully covered SEMs are used. It reduces risk of tumor ingrowth but have high risk of migration. In case of benign stricture, benign esophageal stricture, which is as a temporary measure, SEPs are used. There will be no tumor ingrowth and it has safe and easy to remove, but it has high risk of migration and high rates of stent failure. Esophageal stenting is done in benign conditions like a benign stricture, esophageal perforation, esophagobronchial fistula, refractory esophageal varicose bleeding, and in malignant conditions like esophageal cancer, gastric cardiac cancer, and mediastinal cancer and metastatic cancer. Gastroduodenal stenting is done in benign conditions like benign stricture and in malignant conditions like gastric cancer, duodenal cancer, and pancreatic cancer.
Yeah.
So
just one sec.
Yes, sir.
Dr. Ramakrishna makes the valid point that drugs can also cause vomiting. We were discussing the reasons for vomiting, even though the stent was patent. Yes, I agree. Drugs have to be included in that list. Please continue.
Yes, sir. Intra-procedural complications of stents are bleeding, pulmonary aspiration are related to sedation and stent malposition and perforation. Post-stenting complications are bleeding, perforation, fistula formation, and occlusion of biliary stents. There is 30% possibility of recurrent obstruction due to tumor ingrowth, and there is 10 to 25% chances of stent migration in covered stents and 2 to 5% chances in uncovered stents. And there is 13 to 60% chances of retrosternal pain. These are various types of gastroduodenal stents, and this is the endoscopic placement of gastroduodenal stent, and the image in this slide shows fluoroscopic placement of gastroduodenal stent. Nick S. Ding et al. Conducted a study on gastroduodenal obstruction with placement of self-expandable metallic stents and their clinical outcome. This is a retrospective analysis of prospectively collecting data over 12 years. Patients with malignant gastroduodenal obstruction often have limited life expectancy and will have rapidly deteriorating from complications related to obstruction and starvation. And patients who are not suitable for surgery, endoscopic stent placement can result in rapid resolution of the symptoms. In this study, out of 94 patients underwent enteral stenting. Out of these, 27 patients had primary tumor was gastric adenocarcinoma, 45 patients had pancreatic adenocarcinoma, 8 patients had primary duodenal adenocarcinoma, and 14 patients had cholangiocarcinoma and other metastatic cancer. The stent was placed successfully, deployed in 95% of the cases, and there was an improvement in the gastric outlet obstruction score in 90% of the patients with ability of tolerating enteral diet. The medial survival was 4.25 months without any significant difference between these types of primary malignancy, and the mean hospital stay was around 3 days. Reintervention rate for stent-related complications was 5%. The study concluded that successful deploy of enteral stents achieves excellent palliation, often resulting in the prompt reintroduction of enteral diet and early hospital discharge with minimal complications and reintervention. Jennifer L. Dearborn.
Just hold on. Just
Yes,
hold
sir.
on. Ravi, any comments so far about the stents?
I think basically, this is a situation where one comorbidity and also multiple lymph nodes, and I don't think the patient is ever going to be fit for surgery. Where the indication is right that the patient was considered for the stent, and the problem is it has a lot of complications, and I think it does not offer the kind of palliation you and I would desire many times.
Yeah. Okay. Niranjan?
Yes, sir.
Yeah. Any
This was
comments?
at this point of time, that was probably the best scenario to bring him out and make him eat and see how it goes in the next few days.
Okay.
So probably that was the best case scenario which we had to opt for.
I agree. Yeah. Yeah. But the point that Ravi made is very valid.
Yes, sir.
Do not expect great outcomes.
Correct. That
That's-
I think the attenders, everyone had agreed to that.
Yeah.
So
Dr.
they probably will not even bring him for chemotherapy also.
All right. Dr. Ramakrishna asks, what is prospectively collected data in a retrospective study? Pawan?
Sir.
What is prospectively collected data in a retrospective study? Hari?
Hello, sir.
Yeah.
Sir, after in a retrospective study, we collect patients, and then information are collected about the past, like individuals are sampled and collected. That way, I understood. So I'm not sure.
Not sure. Ramakrishna, what have you to say?
No, 2 slides back, he showed that that particular study. He has mentioned whether he has understood or not. And please go back to that slide, please. What data they have collected? Not this, I think. Still back.
It'll be the next one. Go to the next one. Yeah. No. Next, previous one.
This one, methods, retrospective analysis of prospectively collected data over 12 years.
I think, sir, what they mean is they would have collected the data and kept it, but not analyzed. They've gone back and analyzed, looking at the follow-up case sheets or something.
Yeah.
That is what they mean, probably.
Ramakrishna?
I doubt, sir. Probably what I understood is the cases are retrospective, means the cases are already done. But they will pick up those patients and then they will follow those patients prospectively to see what are the results in the next few months or years. And those data will be collected. Like probably stenting is already done, but now patient is still alive. Whether he develops a complication like obstruction, how many patients die, all those data will be collected prospectively. So that's what I understood, but we have to read that paper completely to understand what it is. He has read it, no?
Yeah.
So
this is a very ambiguous statement. Many people have started making this. To me, it's just a retrospective study. But I think, as Niranjan pointed out, they would probably have a kind of a checklist or a protocol to say what items have to be collected for every case where they put a stent in. That is how they call it a prospectively collected data. But the analysis is retrospective. That is the way I understand it. But yes, we need to look at the original paper to know exactly what was done. Okay, go on, Pawan.
Sir, one more thing.
Yeah.
Is there any definition for achieving palliation? They mentioned the palliation is better with this, that. So is there a definition to
Yes,
say
the
whether
definition.
the patient has achieved palliation?
Yeah, the definition, it is there if they do the study properly, and that has to do with the quality of life scales. Yeah.
No, once in the palliative care principles, I read the symptoms should have come down by at least 50%, and it should be maintained for about 6 months. Then it is called a palliative procedure.
Yeah,
so if
but
the
the patient may
lives
not be
only for-
alive six months. In this case, the median survival was 4 months.
Yeah. So in this case, is it justified to continue with TPN and all? Because just to prolong life, if you give IV fluids and TPN,
Yeah.
it is not justified as a palliative procedure.
But I don't think that was done beyond the point where they decided to give palliation. They were giving
They were
TPN.
doing, sir. They were giving TPN after the
Stent.
no, not stent. After patient has recovered from that episode of MI or something.
No, sir. But TPN was given till the point where the stent was placed.
Stent was
till
put
they
in.
decided on palliation.
Yeah, that's what
After
I thought.
that, TPN was stopped.
Yeah, that's what I thought. Yeah. Go on, Pawan. Okay, Pawan, please continue.
Yes.
You stopped sharing your screen.
No, sir. Actually, 1 minute, sir.
Yeah.
Please share it.
Sir, I think Dr. Swaroop is also there. In the end, you can ask him about his role on comments on chemotherapy and all.
Yeah. We're coming to that. We're still in the literature as far as, go on now. Finish this. Yeah.
Yes, sir. Jennifer R. Dear Brown published a paper on interrelationship between stroke and cancer. Cancer and ischemic stroke are independently carry a large burden of morbidity and mortality as second and fourth leading cause of death in United States. Rate of cryptogenic stroke has been quoted as high as 26 to 40% of the patients, and cancer patients with cryptogenic stroke were found to have elevated D-dimer levels compared to patients without malignancy. Most frequent cause of strokes in cancer patients are traditional cerebrovascular risk factors like hypertension, hyperlipidemia, diabetes, atrial fibrillation, and tobacco use. Cancer may directly or indirectly lead to stroke via hypercoagulability, non-bacterial thrombotic endocarditis, direct tumor compression of the blood vessels, and treatment-related effects which potentiate strokes. Adenocarcinoma is frequently linked with clotting disorders as well as malignancy-associated stroke. It potentiates thrombi via production of mucin, which is a high molecular weight glycosylated molecule which is secreted normally by endothelial cells. It interacts with cell adhesion molecules on endothelial cells, platelets, and lymphocytes to induce the formation of platelet-rich microthrombi. Adenocarcinomas, especially of pancreas, colon, breast, lung, prostate, and ovary, can secrete this molecule directly into the bloodstream, precipitating viscous and hypercoagulable states. Hypercoagulability-induced stroke is difficult to diagnose, and difficult to design a treatment plan effectively, knowing the risks and benefits. Transcranial Doppler is used in stroke patients with cancer to determine embolic signals in middle cerebral artery, and it is more commonly detected in patients with high D-dimer levels. Treatment with anticoagulation was also noted to decrease D-dimer levels. So, correlation between embolic signal and D-dimer levels suggests anticoagulants has the potential to reduce cancer-induced hypercoagulability, leading to stroke. Tracking D-dimer levels may be method to measure risk of cancer-induced embolism or effect of anticoagulations. So this paper concluded that stroke and cancer are intertwined by their relatively common occurrence, and cancer is not the most common etiology of stroke even in patients with cancer. Traditional risk factors are the most common causes. However, cancer-specific mechanism may further increase one's risk for stroke. clinical management of cancer patients with stroke is different from the patients with stroke alone. Stroke extent depends on the activity and severity of the cancer. Cancer patients have poor neurological conditions and tend to stay longer in the stroke unit. Survival rate of patients hospitalized with cerebral infarction in cancer patients than without cancer, and it associated with severity of poor neurological disability and tumor stage. The table shows various stroke conditions and their indicated treatment.
Skip this.
Yes, sir.
Pawan. Yeah.
Jahra Mehdi et al. Conducted a study on perioperative management of adult patients with history of stroke or transient ischemic attack undergoing elective non-cardiac surgery. As per the study, before conducting elective surgery following recent stroke, sufficient time period to be allowed for neurological and hemodynamic status to stabilize and cerebral autoregulation to be restored. As per current evidences, it is suggested to delay the elective surgery for 3 months for patients who had recent stroke. Urgency of surgery and individualized approach to the risks and benefits of proceed with early surgery. For example, in case of non-urgent surgery like elective joint replacement, 3 months waiting period would be preferred. Whereas in cancer surgery, as likely mortality benefits from the urgent surgery is more than the stroke risk, hence early surgery may be considered. Thank you, sir.
All right, just go back 3 slides, 4 slides. So one more. All right. I'll make some comments because, you know, point of care kind of comments, feedback is supposed to be better than giving a feedback later. My first point, you must, I'm talking about your presentation. You must stick to the same tense. For example, you're dealing with a patient whose treatment is already over. So you're saying the patient had this, patient had that, which is fine. But suddenly you would bring in and say there is gastric outlet or there is something. Okay, so you were combining past tense with the present tense, and that is generally not allowed. So you must continue with the similar tense. And I want you to critique this slide yourself. We have repeatedly mentioned certain rules for making a slide. What were those rules?
Sir, the point should be concise and not more than 5 lines.
Yeah, the rule of 6 we said. What is the rule of 6? Hurry.
Sir, 6 lines and 6 words in each line.
Yeah, 6 lines to a slide and 6 words to
6 words to
a line. All right. So you have royally broken that rule in many of your slides, and you are continuously reading your slides. I have repeatedly said, do not read your slides. Have bullet points, which are phrases rather than complete sentences. And if you feel that you may forget some things to say, you are welcome to have notes which do not show up when others are seeing. So kindly do not so blatantly beat the rules of making a slide. Okay, very important. All right, I'll take some questions from the chat box before I leave open for other comments. Shrikant asks, in these cases, which is better, stenting or feeding jejunostomy? Hari.
Sir, actually both, in this case it is stenting, sir.
Why?
Because a patient cannot be taken up for surgery and it is a less invasive procedure.
Why don't you maintain the nutrition by feeding jejunostomy is what Shrikant is asking.
Feeding. Okay.
The fundamental, very fundamental requirement of humans, the satisfaction of eating, will not be there if you have a feeding jejunostomy.
Quality of life.
Okay, so
yes,
there is no role for a feeding jejunostomy. He was asking you guys a very valid question, whether you had understood why stenting was even considered. All right. Earlier in esophageal cancer, they would, before the days of stenting, they would actually do a gastrostomy and do a pharyngostomy. You know, they would have, they would make a hole in the pharynx, in the side of the neck. Patients would eat for the satisfaction of eating. It would come off, and they would, like a colostomy bag, an ostomy bag. They would put a bag on the pharyngostomy, and they would be kept alive by a gastrostomy. All right. So, I mean, I think that is an extreme case. I would have, if you had no option of a stenting, I would have probably allowed the patient to go, but that's a matter of one's choice. But the point is, you must have the very basic satisfaction of eating something. That's why it has to be a stent. What is Victor's triad? Ramakrishna asks. Ramakrishna? Can you come in, please, Ramakrishna? Maybe Idira, can you say what it is?
No, it is Virkos, sir.
Workhouse. Oh, I see. I was about to say, I didn't know myself. Yeah. What is workhouse triad? Yeah.
Oh, it's typo. My spelling.
Yeah, it's okay. No problem.
It has taken.
Yeah. Tell us, sir. Tell us, sir.
No, in pathology, we used to read that. Now he was explaining about the hypercoagulability. So I wanted to ask the
Sir, that is in endovascular damage, hypercoagulability, sir, and stasis of blood.
Correct.
Yeah, yeah.
Those are the three things. Correct. Okay. Comments from the seniors before we close the session. Ramakrishna, you can start.
It's a good case to with so many learning points. But did he have pain? This patient, pain?
No, sir. No pain.
Pain was not an issue from what I could read. Yeah.
Pain was not an issue.
No pain, sir.
No pain. Okay, sir. And what happened to him, sir, till now? Because it was
he's still continuing to feed. Apparently, Pawan had called that attender recently. He is continuing to eat, and he is quite stable as of now. He has not come back for chemotherapy.
Has Swaroop left? He's still there.
Swaroop is still there.
I'm here, sir.
Swaroop, your comments, please. On
good evening, sir. So a question for the students here. Assuming that the patient was stable enough to receive chemotherapy, what would be the next step? There was one investigation to be done on the biopsy specimen before we go ahead with chemotherapy. Can you tell it? Additionally to chemotherapy, I would like to give another drug if he was eligible for the same. Another hint, it's used in breast cancer as well.
Sir, hormonal.
No. I'm giving you a hint. It's also used in some patients with breast cancer. This particular drug.
Anthraceptin.
Yes, trastuzumab. So about 15 to 20% of stomach cancers are positive for HER2 receptors. And there is a trial called as the TOGA trial, which has shown that using trastuzumab along with chemotherapy improves the median overall survival by about 2.5 months. So the median overall survival in these patients is 11 months with chemotherapy, 4 to 6 months without chemotherapy, and with chemotherapy plus trastuzumab, about 13 to 14 months. But only 15 to 20% of patients are eligible for trastuzumab. Further thing which we would like to see in these patients, it's a recent development. We look for the microsatellite instability, MSI, and the PD-L1 receptors. If they are positive, they are eligible for immunotherapy as well. But in this particular patient, it was not an option. The patients clearly told, the relatives told me they can't afford all of this, so I did not get it done.
What I would like your views, Swaroop, about your approach to chemotherapy in a patient who is unfit for surgery. You know, we talk about fitness for surgery. Can you educate us a little bit about fitness for chemotherapy?
Sir, for fitness for chemotherapy, we look at various aspects. One is the renal function, the liver function, the nutritional status, and then we also look at how the cardiac status is. Some drugs are toxic to the heart, such as anthracyclines. Some drugs are renal toxic, such as platinum analogs, and some drugs are hard on the liver, such as the taxanes. So we look at the overall picture, which particular system is more vulnerable, and based on that, we choose either a combination of platinum plus taxane ideally, or we omit one of the drugs if the patient is not fit. And in very unfit patients, we give them leucovorin plus 5-FU, which is a old but effective regimen to an extent.
Thank you.
Yes.
Concluding remarks from
One small doubt.
Sir, I had one question to ask with.
Hey,
Dr.
non-senior Irapa.
Go ahead. Go on.
When do you consider stenting directly without even not considering surgery? Palliative stenting.
Patients unfit for surgery.
Other than that, anything else, sir?
No, because palliation.
Metastatic disease maybe. Preoperative diagnosis of metastatic disease.
Extensive
Even in metastatic disease, you do palliative gastrectomy, no?
Yeah, that's what. If they want to give chemo and try out resection later, that's probably one other road. You put a stent and give chemo and then see how the response is, and probably that's what I could think of.
No, but Niranjan, if you give chemotherapy to patients after a stent, and if there is response, the chances are the stent will migrate.
Yeah,
because the tumor shrinks.
Yeah.
So unfortunately, you can't achieve your objective.
No, but if tumor shrinks, that outlet obstruction also will probably
go. So
go
it may not matter. It may not matter. Yeah. Okay.
So my question to Swaroop was, sir, neoadjuvant chemotherapy role and adjuvant chemotherapy role at the current time. Suppose patient was fit for everything. What is the current role?
The current standard of care is perioperative chemotherapy rather than neoadjuvant or adjuvant. What I would follow these days is the FLOT regimen. So you give the regimen containing of 5-FU leucovorin, oxaliplatin, and docetaxel. We give 2 cycles before surgery, then operate, and 2 more cycles after surgery. Before this regimen came into place, there was the other protocol called the Ecf regimen, which was similar. Instead of this FLOT, we would use epirubicin, doxorubicin, and cisplatin, neoadjuvant and adjuvant. So it's basically perioperative chemotherapy rather than pre or post-operative.
Do the pages need to know all these things?
Yeah, why not? They must at least know
the
the
entrance.
concept.
They do ask, sir, neoadjuvant or adjuvant or perioperative is even better.
Oh, DNB
No, I think even in exams they ask, sir.
Oh,
if there is gastric outlet obstruction, what is the chemotherapy which you may give?
Yeah. Ravi, your concluding remarks.
I think it's a difficult area. I think you are. I think one more thing that this one, even Bailey and very long ago suggested that patients with esophageal cancers, you never put a gastrostomy, and I think it was made very clear because of the quality of life issues. I think Swaroop I would like Swaroop to enlighten us about the quality of life in such patients, because these chemotherapeutic agents are probably very toxic. Are they well tolerated, and is the cure better or treatment better, more enduring than the disease itself?
Sir, that's a really important point, sir, because when we're attempting to cure a patient, we do take a risk of severe toxicity. It's worth it. But when we know that we are doing something palliative, we generally reduce the intensity of chemotherapy. We either give a single agent chemotherapy rather than combination chemotherapy. And that's the usual approach, sir.
Okay.
All right. No more comments, I presume. Thank you very much, Pawan. I think your review of literature was very good. You've done hard work in fishing out these references and educating all of us about these issues. The case was, I think, a very interesting case, and it brought to the fore the importance of non-operative management and the options that we have in a patient who cannot be operated on. Altogether, I think it was a good discussion, and I thank all of you for participating in it. Thank
why the participation is so less, only 10?
It's always the case. So
It's only us now, sir. And Aster group is not coming.
Aster is not
But
coming.
still, after this, already five are seniors here.
Yeah, that is the state. That
What
is
about the residents?
that is the state
Strength
of
step.
Aster ಇರೋದು, there no new batches come ಅಲ್ಲ.
no, that is the state of affairs in the state and the national meetings. We have been there,
Yes.
and so we
There
just
were
have to
22, 23 participants, sir,
yeah
in the
so,
national conference.
yeah. So
Even,
we have
even in the what is that, the regional refresher course, the attendance was quite poor.
yeah. So we just have to do our bit and see whatever the students are interested, they can take out,
Okay.
they can get it out, they can take what they want out of our effort. Thank you very much,
Thank you,
ladies
sir.
and gentlemen, and good night. I'll close the meeting now.
Thank you.
Good night.
Thank you, sir. Thank you, sir.
Thank you.